Okay, I want to start off by saying two things. One, I think Dr. DePetti should write the new pap smear algorithms because he's much better at it. And two, whoever brought up before that the algorithm says that, that after 1 year, if you're still HPV positive, you should do a colposcopy. I'm glad that that got brought up because when I sat down, I thought, how could I have gotten that so wrong? And so I looked at the algorithm, and it's interesting, if you actually follow the algorithm and you go back to the top, it still gives you that option of checking for HPV 16, 18, and then you go down the same thing. So unless there's some fine print somewhere, you can interpret it either way. And I think that's a great example of how bad our algorithms are right now. And I think that's the importance of knowing that pap history, because if we had an HPV positive last year, if we had an HPV positive the next year, if we didn't look at the algorithm, we would do a colposcopy. So I just think that's important. I know I talked too long before. I'm sorry, you should have cut me off sooner. I will try to go really fast and keep us on time. But these were some interesting cases that I had this year, and I feel like the more I practice, the less I know. So I'm just going to start. 58-year-old G2P2 comes for an annual exam. Menopause, 52, no hormone therapy, no symptoms, PAP's normal, hypothyroid, on Synthroid. Everything's fine, non-smoker, glass of wine. Family history, you know, a little bit of everything. Everything's fine, we're gonna do a PAP, maybe we're gonna send you home, do your mammogram. Then she says, you know what's interesting? For the last 2 times I've had sex, as soon as I hit orgasm, I have a really bad, sudden, severe headache. And I thought, I've never heard that before. My initial response was, well, you know, take an Advil before you have sex. I said, but let me look into that and I'll get back to you. So I looked into that and I'm really glad I did. So there are things called sexual headaches or sex headaches. They're rare. The lifetime prevalence they think is about 1%, but they don't really know. They don't know why it happens. It may be related to the excessive neck and muscle contraction that happens during sex or orgasm. Maybe a migraine variant, that's a funny trigger. Possible relationship with exertional headache. And so most of the time, that's all it is. So take an Advil before you have sex might actually work. The diagnostic criteria, believe it or not, it has diagnostic criteria. 2 episodes of pain in the head or neck, brought on by or occurring during sexual activity only, increasing intensity with increasing sexual excitement or explosive with orgasm. I know, no pun intended. Lasting from 1 minute to 24 hours with severe intensity and or up to 72 hours with mild intensity. And it's not better accounted for by another headache diagnosis. Okay, so that I thought was very interesting. So is this just a headache? So let's think about it. The act of sex requires musculoskeletal input, right? Lots of vascular processes and lots of neurologic processes. So can I tell her just take an Advil when you have sex? When I actually looked it up, that was me going, oh my God, thank gosh I looked this up. And maybe the internists in the room would know this better than the OBGYNs. But the differential diagnosis of sex headache is frightening. Look at that. Vascular, subarachnoid hemorrhages, cerebral vascular syndromes, cerebral vascular vasoconstrictive syndromes, arterial dissections, coronary artery disease, brain things, heart things, meningitis, encephalitis, hemorrhage into a cerebral tumor. So this woman, I called her back and I said, about that whole Advil thing. The differential diagnosis, again, pure sex headache, but then you have to go through all the other cardiovascular neurologic things. There are case reports where it's actually happened, where the diagnosis has turned out to be sinusitis, glaucoma, COPD, and Cushing. I don't know how Cushing, maybe you can tell me, but that was a case report. I didn't say a good one, but it was a case report. Can you tell the difference? Characteristics of the headaches. There's the pre-orgasmic ones and the ones that come on with orgasm. Dull, again, you can read the difference. The orgasmic ones seem to last longer than the pre-orgasmic ones. Either can be a sign of an underlying neurologic or vascular condition. So the bottom line is no, you can't tell the difference by the timing that when it happens, although there were several references that only if it's with orgasm are you worried about it having been an acute stroke. And again, that's probably related to the hypertension, the increased cardiac output, all that. So the bottom line is, can you tell the difference? No. So the evaluation, we have to look at the brain and the heart. We're not used to looking at brains and hearts. So I called her and told her she had to go to somebody who looked at brains and hearts. If it happens, if she had called me in the middle of the night on call, she should have gone right to the emergency room for an acute evaluation that they say it's the equivalent of a thunderclap headache, which is the most severe headache of my life. You go to the hospital, you get ruled out for all these things. She would have wound up with a head CT and an LP if it happened acutely. Since this was not acute, I referred her, and she wound up with an MRI and an MRA, a CT angiography, and a conventional contrast angiography, and then a full cardiac evaluation. So they did every test known to man on her. Every test came back negative, and we told her, yes, this is just a sex headache. So the acute treatment is you can treat it like a migraine. It will often respond to triptans, about 50% response. Recurrent headaches, you can use indomethacin 30 to 60 minutes prior to intercourse, so at least my initial instinct was right, although it was the wrong choice of agent. Preventative propranolol daily dosing, again, you're kind of treating these like migraines, and sex is the trigger. Preventative triptans prior to intercourse, and I suppose the prognosis, no long-term sequela, that after the initial headache, 25% will go on and have this as a chronic course. And if you do have it on as a chronic course, it's not a permanent chronic course. There's a very high remission rate at 3 years of about 70%. So people don't know exactly what the trigger is when it happens. But I was very surprised because I would have treated this a little bit less seriously than it really is. And this was the first time in 25 years that I ever had somebody come into me with that complaint. So I thought it was interesting, and I learned something, and I will pass it along. I'm going to move quickly here because I'm trying to keep us on time. I have 3 of these. I have 4 of them. The 4th one we can always skip. Unusual allergy is my second one. 26-year-old presents with vaginal irritation. 3/4 of my patients have vaginal irritation because that's what I specialize in. But she says it happens only when she has sex with her current boyfriend. Immediately afterwards, lasts about 12 hours. Burning, irritation, swelling. She doesn't use any lubricant. She's not using any toys. They're not applying anything. She feels aroused. She has no pain with sex. She's had 2 other partners in the past without problems. She does have a Skyla IUD in place. Her past medical history is significant for eczema. So she comes in and says, I looked this up on the internet, and I think I'm allergic to my boyfriend's semen. And I thought, I've heard about this, and even when I mentioned it to some of my partners, they were like, is that a real thing? So I said, okay, let me see if this is a real thing. So I looked it up, and it is a real thing. One definitive question that answers, and that answer is, does a condom prevent symptoms? If the condom prevents symptoms, yes, it may be a semen allergy. If the condom does not prevent symptoms, then it's not a semen allergy if you're using the condom properly. So it's a very distressing thing to think that you might be allergic to your partner's semen. So what's the incidence? Again, it's unclear because to diagnosis, which we'll go to in a little bit, most of us are not going to go through what we have to do for the diagnosis. But there was one survey that was sent out to 1,000 women, and of those 1,000 women, 130 reported symptoms that could, if evaluated properly, have been possible allergic reactions, and that include 46 localized, but also 86 systemic anaphylactic-like reactions from semen. The etiology, it's not actually a sperm allergy. That's why my little sperm looks happy. It is an allergy to one of the glycoproteins in the seminal fluid. There was some question that it was actually PSA, but they're not particularly sure that that is the glycoprotein that it is causing the problem. The risk factors are a history of any allergy or allergy syndromes. Remember, she had eczema. And in 80% of women with semen allergy, that is one of the risk factors. Case reports say that it has happened after long intercourse-free periods. Sometimes it's new onset with menopause. Sometimes after insertion of an IUD, after hysterectomy, and in the male, if he's had a prostatectomy or a reversal of a vasectomy. So it may be that something is changing in some of the immune factors or something in the hormonal milieu of the, or whatever that word is, of the vagina that is causing this to happen. 41% occur after the first episode of non-condom protected sexual intercourse. The largest case series of semen allergy, there are 74 women. This is from 2004. Local reactions were 33%, vaginal irritation, itching, burning, edema, localized hives, or even eczema. 70% had systemic symptoms, mostly pruritus or itching. 21% had anaphylactic reactions, although there have been no reported deaths. So that's a little bit frightening. Differential diagnosis, we all kind of know this differential diagnosis. Is there an allergy going on to something? Are you using a spermicide even if you're not using a condom? Are you using a spermicide? Are you using any lubricants? Is it really an allergic reaction at all? Is there another pelvic condition going on? Could it be vulvodynia? Lots of my vulvodynia patients have the same kind of symptoms after they have sex. Is there a vulvovaginal infection? Is there a contact dermatitis? You have to think of all those things. There's actually reported cases where there was a food allergy in the woman. It was actually a nut allergy. And she had sex after he had eaten nuts. And she had an anaphylactic reaction. They examined his sperm, or his semen, and found peanut protein in his semen. So very interesting. So think about that if you have, again, I have a son who's allergic to peanuts, and I always tell them, please, if you go out with somebody, they can't have any peanuts because you might be kissing them. For the girls, it could be even worse. I'm not sure if it could happen the other way around. I suppose it could. It could be in the vaginal fluid as well. I'm not sure. I didn't look that one up. Maybe next year if I come back, if I'm invited back. So this was her. How do you actually diagnose it? There is anti-seminal plasma IgE testing available, but it's not reliable, so don't spend the money. You can do skin testing. Have the partner bring in a sample and do a scratch test or inject it underneath the skin. A single specimen, if it's negative, you can consider separating the different components out and concentrating them to see if you can tell. What's interesting is what they say is that the male partner should also serve as a control. I'm not sure why. Maybe, I don't know, just it's fair is fair, right? If the wheel is greater than 3, it's positive. It is an IgE reaction. And again, they're thinking it may be to a PSA antigen, but that is not consistent from studies. I don't think a lot of us are going to do that kind of skin testing to determine if it's an allergy. I suppose I suppose it's something to think of. I would never have thought of doing that, but it is certainly a possibility. When my son was little, we thought he might be allergic to kiwi fruit. And they didn't have a kiwi fruit antigen, so they actually had us bring in a kiwi. They mushed it up and they injected it into his skin. Unfortunately, he was allergic to the kiwi fruit. Trivia completely unrelated. See, this is why I talk too long, because I get distracted. A little bit ADHD going on up here, I think. People who are allergic to kiwi, what is a very common allergy that they also have? Latex. I would never have thought that. Kiwi and latex are very close in terms of allergies. Anyway, to go on. Treatment, condom use. That is really the treatment that most people are going to use. If the guy has a vasectomy, it's not protective. Why is it not protective? Because it's not the sperm you're allergic to. Prophylactic medications, pre-medicate with antihistamines. And again, this could be my favorite quote of this lecture. Sometimes it's effective and sometimes it's totally ineffective. And that was from the review article. So I'm not sure I would count on that. And again, favorite quote of the lecture. You can desensitize. It's interesting that the desensitization, intravaginal or subcutaneous routes using the partner's semen. You do it in a single appointment. Again, this is something the allergist should do because they are used to handling anaphylactic reactions from their testing that they do in their allergies. Once you do that, you start with a little bit, just like any food allergy, you start with a little bit, put it in the vagina. If they don't react, do a little bit more, do a little bit more. And you can desensitize them, they say, quite quickly in one session. Again, I'm just reporting what I read. Once you do that, you have to continue to have unprotected intercourse at least twice a week for maintenance. And the results of that are variable. What happens if they want to get pregnant? Because you can avoid this if you use a condom and you use it properly. You can try the desensitization method. Usually, it's a mild local reaction. Unless it's a mild local reaction which responds to antihistamines, then you can just, when you're having unprotected course, if you're one of the people where it works, use the antihistamines. Intrauterine insemination and extensively washed sperm. I don't know, maybe you wash them twice, but you have to really wash the sperm because you don't want to take that allergen and put it into the uterus. There's no apparent effect on fertility because, again, the allergy is not to the sperm. So I think that anaphylaxis, remember, just like in food allergies, severity of reaction may worsen over time. So you want to let the woman know if she truly is having allergy to the sperm. If it's just itching and irritation, over time it can become more systemic. And I suppose if somebody is anaphylactic, that would be a really good reason to do the skin testing so that you really know what they're anaphylactic to, because they need to know. Condom use mandatory. And again, these are people who need to have an EpiPen. Okay, that was my second. Any comments or questions on the semen allergy? Ooh, lots of hands.
I was just going to ask that patient, did she have previous partners?
She had 2 previous partners with no problem. So you have to look at the partner's history as well.
So is semen allergy a semen allergy, or is it individual? It's based on the individual semen?
It's variable. There are some women where it happens in any partner that they have, and then there are some women where it's only select partners. Anything else? No? Okay. I'm sorry, I'm going fast. I'm trying to keep us on time. Thank you for staying and hanging in till the very end. I appreciate it. Okay, my next case is I don't think this is your fibroid case. 44-year-old G2P2 came to me complaining of pelvic pain. The pain was right-sided, intermittent, worse with sex, standing, and with her period. Her periods are irregular, about every 2 months, up to 7 days, not really heavy. Pain's been present for years. She had a laparoscopy with lysis of adhesions 2 years ago. The pain was gone over those intervening couple of 18, 20 months or so, and then it restarted about 4 months ago. She's otherwise a healthy lady. Her only surgery was several years prior to, she had a laparotomy for an ovarian cystectomy and a myomectomy. Didn't have any of those op reports, and she didn't have a lot of information about it. And then in the 2 years prior, 2016, she had a laparoscopy with lysis of adhesions. She had no bowel or bladder symptoms. She was otherwise well. BMI 33, everything was pretty normal. Tenderness in the right lower quadrant, but nothing that was acute. No hernias. Her prior incision was intact. Everything looked fine. Pelvic uterus was top normal sized, wasn't really tender. She had a little bit of tenderness in her right adnexa, but there were no masses. So pretty benign exam. She came to me having already had a CT, which was negative, and a pelvic ultrasound done at another institution that said she had a 2.8 centimeter anterior fibroid that was subserosal and normal ovaries. So she came to me and said that whoever had ordered those prior tests told her that, and I think it was probably the ER, told her that she should see her gynecologist because she had a fibroid and the fibroid was giving her pain. Okay, so how many people think her fibroid was giving her pain? Okay, good. I'm glad you all agree with me. She had a negative urine, negative normal cultures for gonorrhea, chlamydia, normal pap smear, basically otherwise was a well woman. So my management, because she was healthy, I said, well, let's start you on birth control pills, because if we can maybe fix your cycles, get you regular cycles, you have a history of ovarian cysts, pelvic pain, birth control pills, right? Go hand in hand, first line. She took them for about a month, but then she stopped because they didn't help. So I told her, it really isn't going to matter. It's not going to tell me, right? 1 month is not long enough time to see if your pelvic pain is going to go away. She came back to the ER about 4 or 5 times. She came back to the office multiple times. Diagnostic, we wound up doing a diagnostic laparoscopy on her, thinking there is a chance she's had a prior myomectomy, prior lysis of adhesions. I hate to fall into this laparoscopy pain, laparoscopy trap. She refused any other intervention. She wanted a uterine artery embolization. That's what she wanted, because it was her fibroid and her friends had uterine artery embolizations and they worked for their pain. And I said, no, you're not getting a uterine artery embolization. This diagnostic laparoscopy was probably after about 8 months. So it's not like she took the pill for a month and then we tried nonsteroidals. I sent her for other consults. She had her everything was negative. Finally, about 8 months later, we said, listen, we'll do the laparoscopy. She had a 3 centimeter pedunculated fibroid, no pelvic adhesions, no endometriosis, a very, very clean pelvis. The mistake at the diagnostic laparoscopy, which I didn't actually do, was that the person didn't take out that 3 centimeter fibroid. Since it was on a pretty thick stalk, so I think that's why it wasn't taken out. I don't think there was a good indication to take it out, but it wasn't taken out. So she came back and said, well, I know it's this fibroid, and I can't believe they didn't take out that fibroid, and I want my uterine artery embolization. And I said, no, we're not going to go back and take out that fibroid. We are not going to do the uterine artery embolization. It's not indicated. Does anybody think it's indicated? Thank you. Re-examined, I diagnosed her with high-tone pelvic floor and referred her to pelvic pain, pelvic floor physical therapy. I told her if she went through all the physical therapy, if her pelvic pain, her pelvic floor improved and her pain didn't, we would consider maybe doing a hysterectomy as a long-term management, but we would not go in just to take out her uterus. Again, was this even an indicated hysterectomy? Probably not. I was falling into the pelvic pain trap. I would have, again, long-term plan, very long-term, I would have tried gabapentin. I would have treated her like a pelvic pain patient You can tell that she was not going to be a very compliant pelvic pain patient, and I would imagine what happened, which is what did happen, was I lost her to follow-up. I wasn't doing what she wanted to do, so she went away. Well, I found her from follow-up about 6 months later when she called me saying, oh, Dr. Phillips, I'm in such and such hospital. I had a uterine artery embolization done and there was a complication. I don't think they're treating me right here. Can I please get transferred over to your hospital? I said, well, what's going on? Well, part of my left butt is a little bit sore. I said, well, what do you mean by sore? Well, the skin is broken down a little bit and it's really sore, and they're giving me Silvadene ointment for it, but it's not really getting any better. So I thought, that doesn't sound very good. So we accepted her as a transfer back into our hospital. Before I finish the story, we're going to go over uterine artery embolization, right? We started doing it around 1995, transcutaneous femoral artery approach. We all know this. We embolize the arteries using the polyvinyl gelatin microspheres, fibroid devascularization, involution. About the success rate, about 42% decreased size in fibroids over 3 months. Those of us who take care of patients who have them, when we send them for them, usually the bleeding improves, and most of the time we're doing it for bleeding, right? And the bleeding generally improves pretty quickly. 89 to 90% have success in improving symptoms. Sometimes the pain symptoms, I don't do it much for pain. You do it for kind of, bulk, big fibroids, lots of bleeding, and generally it sometimes takes a little bit longer to get better in terms of the pain, but usually the bleeding improves pretty quickly. Remember, she was having no bleeding problems, and she was having very intermittent, inconsistent pain. Indications, again, we know heavy menstrual bleeding, dysmenorrhea caused by intramural fibroids. To have that, you have to actually have an intramural fibroid. They need to be premenopausal, no desire for future pregnancy. It is less effective on bulk symptoms, just because bulk symptoms tend to be on much bigger uteruses, although it does work fairly well. So again, by our laparoscopy, she had a pedunculated fibroid, and that's really not an indication for a uterine artery embolization, but she doctor shopped until she got a doctor who did what she wanted to do. If we had that versus a hysterectomy, shorter time to return to work, less post-procedure pain, although there's a higher minor complication rate and a higher hospital readmission rate. The readmission is generally for pain. In our institution, we usually don't even send them home. We let them stay. The overall complication rates for uterine artery embolization is approximately 5%, mostly hematomas, UTIs, pain. Not really major complications. Again, you guys know this. Contraindication, pregnancy, postmenopausal, pedunculated fibroids on a narrow stalk. At least she had a wide stalk. This is how she showed up. She had right gluteal necrosis. They were treating that with Silvadene. Okay? So she came, we started her on IV antibiotics, put her on PCA for pain control, because as you could imagine, this was incredibly painful. We had our pain team look at it and said, well, try wet to dry dressings, although it already looked pretty darn necrotic, so we tried wet to dry dressings for probably about 15 minutes or so. We got a general surgery consult, a plastic surgery consult, an ID consult, the pain management team, and the wound care team. So we did a little bit better than Silvadene. Again, what happened in her, and I'm not going to belittle this point, but when you do the uterine artery embolization, you want to go up through the femoral, down through the common iliac, down to through the femoral, through the common iliac, internal iliac to the uterine artery. What happens if you go a little bit above, you hit the inferior gluteal artery? Now, in most cases, you don't actually go into the wrong artery. In most cases, you can have retrograde fill. You put too much in, so you retrograde into the artery, or you can have a thrombosis, in that artery. So yes, it's possible they went into the wrong artery, but it is also possible that it was just retrograde fill and not directly their fault. Directly their fault for actually doing the procedure to start out with. So it turned out that she wound up with 3 operative procedures and a 30-day history, a 30-day hospital stay. So we initially tried to put on the wound vac to see if we can get any improvement there. Took her to the OR to debulk it the first time. Took her to the OR to debulk it the second time, and that's how she went home. So she, it doesn't look much different than it did when she came in, although you can see the depth of that incision. That basically now they're going to let it heal by secondary intention, and then she's going to probably need some plastic surgery to reconstruct that. Yes?
So where is she in the healing process? Like, has she had the
She has had, no, she is actually, she's granulating in. It looks pretty good. Her pain is much better. She's not on the opioids anymore. She's on non-steroidals. She still has the dressing on, and she comes back once a week. And she's doing really well. That's the latest picture that I had of her, was before she went home. So again, she could have also had, I forgot that one before, she could have had anomalous vasculature. Okay, what did this case teach me? Integrity, right? Don't do surgery. You can really hurt people. I always tell my residents, think of the worst possible outcome and then work your way backwards and see if you can justify it. Because we're all going to get bad outcomes. It's just going to happen. But you have to be doing it for a reason. Also taught me the importance of consults. We had an entire team working on her. And good charting practices. The fact that I had declined her having this procedure at least 3 times and having documented that I talked to her about it, I actually didn't do the procedure, but again, good documentation of this. And it's 109, humility, because alone I could not have taken care of this. This one, I'm just going to go through the long and the short of this case in the sake of time. I think we've covered this a lot. 17-year-old comes in requesting an IUD. Her friends all love theirs, and she's bad at taking pills. She currently uses condoms, will continue to do so. Periods are irregular about every 3 months. She has no medical problems but severe acne. Her BMI is 34. Right? This isn't something that per se taught me something this year, but this is something that reminded me how other people sometimes don't pay attention to details. So, do you think she's a good candidate for an IUD? Yes and no.
Yes, in the sense that it sounds like she's PCOS and she has oligomenorrhea. Yes, in the sense that she sounds like she has PCOS and oligomenorrhea, so being on something like a Mirena would decrease endometrial hyperplasia and risk, but so would OCPs. Granted, she's non-compliant, so it's one of those cases where you could do an IUD for contraception, but maybe do the OCPs for acne at a low dose if she has no other contraindication.
Right. So I have this year alone, I made her a patient coming in new, but this year alone I have probably either taken out or adjusted Mirena IUDs or Skyla IUDs on probably 5 or 6 people who come to me, who come in, again, complaining of worsening acne on the IUDs. And I haven't had hirsutism, but I'm sure that's out there too. So again, just like you said, she has PCOS. You know, is there a fix-everything contraception for her? Sure, combined oral contraceptives, but she doesn't want them. She's not going to remember to take them, and she's going to come back pregnant, which will fix her PCOS temporarily, but not quite in the way we want it to. So up to 85% of adolescents experience acne caused by those 4 things, blah, 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 blah. Stimulates the follicular hyperproliferation, sebum production, bacteria, inflammation. And Usually there's some influence of genetics and probably also diet. What happens in adolescence? Adolescence is a really hard thing to be anyway, and there's significant psychological morbidity with acne, loss of self-esteem, embarrassment and anxiety, and there's social and professional implications. Whether or not we admit it, you know, your first impression matters, and we look, and people see that, we notice. So again, why am I talking about acne as a gynecologist? Because it all starts with those androgens. Initially, DHEAS at andronarchy stimulates sebaceous glands, continues through puberty, testosterone production in the ovaries and the adrenals. The androgen receptors in the sebaceous glands and the follicular epithelium are all affected by androgens. Increased androgens lead to increased acne. There is, I put that picture in there for Ronnie, who's the only one who understands it. Again, we all know lots of androgens leads to lots of acne. Combined oral contraceptives and acne, they decrease acne by those, again, we know the two ways. We decrease ovarian testosterone production and we increase sex hormone binding globulin. There are 4 FDA approved pills, FDA approved for acne, but we know that they all work. What about the LARCs and acne? Levonorgestrone containing IUDs and Nexplanon. We know that the use of LARCs in this population is growing, which is a really good thing, and we should continue to encourage them. But 14 to 15% of women who use Mirena will experience skin issues like acne because of the levonorgestrel in the IUD. There was a 3-year prospective study. There was 13% in the copper, 18% in the progestin implant. Again, it's a high-risk population for acne anyway, but that was statistically significant. And in a retrospective review, the levonorgestrel IUD, again, 17%, and in that population, there was a lower percentage of acne. So we have to consider that when we're offering IUDs to this population. So should we abandon them? Absolutely not, right? Because we don't want them to be pregnant. But we need to counsel them about it. Consider adding something to help with their acne. Give them some spironolactone while they're using the LARCs. You can refer them to dermatology. I know there are a lot of other ways to treat acne. Talk to them about topical washes. Talk to them about the over-the-counter products. Add the spironolactone. I personally, as a gynecologist, am not comfortable going any further than that in terms of acne. So get your dermatology friends involved, but make sure patients know this going on. And that's it. Look, it's 1:15. I did it. Yes?
NuvaRing would be an excellent option for her. And the other thing that with my young patients that say, I just can't take a pill. This sounds silly, but I said, do you forget to brush your teeth? And most of them look at me like, no. I said, okay, get a rubber band, put it around your pill pack, put it with your toothpaste. You got to pick it up a couple times a day. And most of them can do that and take their pills.
Okay. Fantastic option. With the NuvaRing, I love the NuvaRing. I think it's great. You can tell from the minute you mention it if people are going to love it or hate it. It's hard to convince them otherwise, but it is a really good option. But yeah, don't. And again, I hate pulling IUDs because of acne. Thanks, everybody. Enjoy the rest of your stay here. Thanks for listening to me.